Hi, I'm Emma Deegan, and welcome to the Biometry course. This is the first module of 8, and today we're going to kind of look at the basics of vision and anatomy. I have been working for a while in ophthalmology and training, so hopefully I can impart some of my wisdom. And what would be great is if you want to ask questions, because that's really the way that you know. And I want you to be able to take what we do on this course back into practice and use those skills that you're going to learn now. You can email me at emma@clinicaltrainingsolutions.co.uk, or obviously in the class as we go through, whatever works for you. But yeah, if you have any questions, then please ask. So to start off, what we need to know is more information about you. So which optical biometer do you use? For instance, most people in the UK will have used the IOL Master 500 at some point, and those lucky enough have managed to upgrade it to the IOL Master 700. Now, there's some key differences between those two models, mainly around the formula and the way that the measurements are taken. Or you might use a lens star machine or a pentacam. So there's lots of different types of machine, and I want to make sure that you're getting the most out of this course. So if you're using a specific machine, I want to be able to go through tips that are relevant for you. Okay. And also when it comes to ultrasound. So ultrasound is a part of biometry, and it's used mainly on the dense cataracts. Are you performing ultrasound, or is it something that you would like to do? Or is it something that, although you don't do it, you want to know a little bit more about it? Okay. So again, we can go through about how ultrasound works and to get axial length measurements. Okay. And similarly with topography, it's useful to know because topography used to just be in the corneal department, but now a lot of the doctors doing private cataract work or in big departments, they will use topography to work out what the best IOL is for them. So I want to go through that with you as well. Even if you don't use it in your department at the moment, you never know what's down the road. So we will cover all of these things as basics. And also it's useful to know if you have toric IOLs and are using them in your hospitals, because then that will become relevant when we do the topography in module 4. And do you use multifocal IOLs? Normally, this is in the private sector, so you wouldn't find in a general sort of district general hospital to be using multifocals, but it's useful to understand what these lenses do. And again, towards the end of the course, module 7, we will run through different types of multifocal and toric lenses. And also, one of the things to find out is who orders your IOLs, because that will become relevant when we start talking about formulas and about different types of lenses. So it's good if you know who the person is, then you can go and ask and find out what your particular hospital is doing. So today we're going to concentrate on the anatomy and look at the areas which are important in IOL calculation. We're then going to think about what a cataract is and how we see. So vision is very important, and I think it's very useful to understand vision in your day-to-day job. So if somebody has a -5 prescription, you'll have a profile of them built up in your mind, and you'll expect certain axial length or K readings to be a certain way. Okay, so understanding the vision and how it works is really key to anything to do with the eye. We'll also look at the average measurements, and you'll be sent those in the handout for this module. Average measurements are brilliant, because if you don't know what average is, you don't know if the measurement that you've just taken is good or not, or if you've just taken some way out of spec measurement and it's an artifact and all of that. So average measurements are good to learn for the specific areas that you're looking at. And then once you've got those sorted, you can go on to a few of the others. So I have included other average measurements in your handout. And then spectacle prescriptions, because if you don't understand how the spectacle prescription relates to that person's eye, it's going to be difficult for you to understand their biometry. Measuring biometry is all about looking at the length of certain things, and then we can put them together to make a calculation. However, if you don't understand what normal is, or you don't understand what a prescription is, it's going to be very difficult for you to learn. So hopefully by learning these little areas, it's going to help you. We'll also look at something called spherical equivalent, and that is a way of averaging a prescription, if you like. And we'll talk about different types of test chart. So this is the first slide of the module, and it's quite useful. It's on your handouts, and it just gives you a picture of the eye, and you can look on it and see which parts of the eye are useful. So here, this is the pupil. That's the gap here in the iris, and beneath the pupil we have the lens, and then down here we've got the optic nerve, and to the side of that we've got the fovea. So if you think about vision, light is going to come in here through the cornea, which is clear, into the lens, and then it's going to come down here to the fovea, and that's how you get your vision. Now, a cataract is a thing that's in the way. The cataract is this big lens thing, and it will be maybe dense, and it will stop the patient seeing so well. Okay, so in a cataract surgery, we're going to remove this lens, and if we know how long the axial length measurement is, and if we know the K readings, then we will get a good calculation for an appropriate lens to put in the eye. In terms of the cornea, I said we just go back to basics. So the cornea, you've got the outer layer, which is called the epithelium, and that basically protects the rest of the eye, down here, the stroma, from penetrating implements coming your way, like a dart or something like that. And also this epithelium, over a period of a week, it will actually slough off, a bit like the skin on your hand. Okay, so that means that if you do damage the epithelium, the eye's going to heal itself in about a week. So generally, scar, as long as it's not infected, will start to get better after a couple of days. You'll start to see the scar looking better. Okay, so that's the purpose of the epithelium. Okay, one is to regenerate every 7 days, and the second is to help prevent foreign objects getting into the eye. The Bowman's membrane, which is at the bottom of the epithelium, is quite shiny and very tough, and this membrane is really there to prevent foreign objects getting into the stroma. Okay, if you see any corneal surgery done, you might see the doctors get to the Bowman's area, and then you'll see it's very, very shiny and very flexible, and it's very difficult to get anything through that. Okay, so really Bowman's is just the strong boundary layer. And then the stroma is the bulk of the eye. And this is made up of these collagen fibers. And these collagen fibers are stretched to a point where they are, they're not visible, okay? It makes the eye, the cornea, transparent. And that's what we want. So if you, say, have an increase in fluid going into the eye, then what you'll find is that these collagen fibers flow apart, and then you are going to find the cornea getting hazy, okay? If you have, like, the dart accidentally goes into the eye and that penetrates into the stroma, that is going to cause a scar in the eye. And what happens is that the collagen fibers, instead of growing back all nice neatly, they grow all over the place. And that's where you will get a random scar in the middle of the stroma that you wouldn't be able to see through. Okay. Decimase membrane, this is at the bottom of the stroma, and this really controls water flow in and out of the eye, in effect. So you have the desmosed membrane, and then just beneath it, you have the endothelium, and the endothelium is going to control the water going in and out. So it's only about, I don't know, maybe 10 microns thick. It's quite thin. And you'll notice in patients who have poor endothelium that they have water coming in and out of their eye, and they end up getting sort of white corneas and stuff like that. Okay. So that's roughly the corneal anatomy. It's about half a micron thick. And recently, or like 2013, 2014, Professor Dewar developed another layer of the cornea, which is quite interesting. And this layer came about, it had always been there, it's just that we'd never noticed it. And he was doing some bulk surgery. So he was removing the endothelium and replacing it with a new donor endothelium. And he found that in order to get the endothelium off, he had to go sort of almost to the bottom of the stroma and then take that part, so the stroma, the endothelium, all off together. And what he found was that there was a natural pocket. So when he looked here, above where the bulk of the stroma is here, and towards the bottom, this was where this natural area was. It just naturally cleaved apart, and he decided that that could be a layer. And you can see it when you look at these slides, and also on here on a couple of different slides that he's published. So we can now say that there are 6 layers to the cornea. In terms of dimensions, the cornea is about 11.5 to 12.5 millimeters. It's a good measure of size of the eye as well. So if somebody has a very large white to white reading, you might think that that patient has got quite a large eye, or if they've got a very small one, you might think you need to use a different speculum because the patient has a very small eye. Okay, the thickness about 0.5 millimeter. Normally we say 550 microns, and the curvature, so the K readings, which we'll talk about, between about 43 and 46 diopters is pretty normal. We express corneal readings in diopters because for the doctors, cataract surgery is a refractive procedure. They're taking someone's prescription, they're doing some surgery, they're putting a lens in, and they want the patient to have a good outcome in terms of their vision. Okay, so it helps them to think of everything in diopters. If, however, you go and talk to your optometrist, they will probably work with everything in millimeters because they're normally fitting something to the surface of the cornea. Okay, so if you get confused, the numbers look very different. So a normal range here is 43 to 46 diopters. If you are looking in millimeters, you might have something like 7 to 8 millimeters. So there's a big difference in the number. Okay, and then the other structures we can think of are the limbus. So the limbus is a little ring around the sort of clear part of the cornea, and then it kind of goes into the sclera and the conjunctiva. Okay, now that little ring is very important because that's where the blood supply stops. No blood vessels should pass through the limbus and onto the cornea, because if they did, then the patient won't be able to see because there'd be lots of blood vessels. So if you've ever seen anybody who's had an acid attack, this is what their eye will look like. It'll probably be very white, and it'll probably have these red vessels going all over it. Okay, but in a normal eye, we don't, or healthy eye, we don't want that to happen. Okay, so the limbus is important, and it's also important because it contains some of the stem cells. So sometimes if patients have to go for a graft, it's important that we have some stem cells for them. Okay, and that's really what it looks like. So you've got the limbus here is at the edge, the anterior chamber is this part here, The cornea is the big dome, the big clear dome. And then down here, we've got the lens, some zonules which hold the lens in place. And then we've got ciliary body and the canal au Schlem. And the canal au Schlem, or the trabecular meshwork, are ways that the fluid will flow out of the eye. Okay, so the anterior chamber is made up of the aqueous, the iris, and the pupil. And it's important to us because of this area here. So this is your iris and this is your cornea. If somebody has a cataract and it grows really big and thick, it will force the iris up so that the iris is now sort of on the inside of the cornea, and that will block any tissue, any fluid leaving the eye, and it will mean that the pressure in the patient's eye goes up. So some doctors, especially the glaucoma doctors, will be quite interested in looking at these angles as well as the normal biometry measurements. And also some of these glaucoma doctors will know that if they remove this, a bit like removing a cube of ice from a drink, that the water will go down in your glass, and so the pressure will go down in the eye. So for some patients with glaucoma, that's a very neat way of treating the eye. Okay, so aqueous flows to maintain the pressure in the eye is ideally what you want to have, normal pressure, and what you don't want is for the pressure to become blocked, or over a long period of time for the pressure to be high, causing damage to other parts of the eye. So the crystalline lens normally is about 10 millimeters wide by about 4 millimeters thick. So if you had a patient coming in and they were, say, in their 20s and the lens thickness was about 10 millimeters, that would be odd because 10 millimeters is for like an average person, okay? And it gets thicker as you go older. So if their lens is already a bit thick, then maybe there's something else going on and the doctor will want to do a few further tests, okay? But it's like, if you look at the lens thickness, that's the first sort of thing to note. Is it a normal thickness for the age of the patient? Okay, and all it is, it's a collection of cells. It looks a bit like an onion when you look at it. And what happens is that these cells inside the lens kind of slough off, and then they become opaque with these buildup of cells. So that's really what a cataract is. Okay, and we use these measurements to then calculate the replacement lens. So we can take the old lens away and put in a new plastic lens. Okay, we need to know the axial length, the length of the eye, and also the K readings. And if we know those two, then we can calculate the power of a lens. If you think about a projector in front of a screen, you know that if you move the screen back, that will affect the focus. And so then you have to change the focus style on the front of the projector. So the eye's like that. Basically, if you have a long eye or a short eye, you're going to need a different power in order to correct it. Okay, for some formula, the anterior chamber depth is useful. And this is how I meant that it looks like an onion. So this is a cross-sectional image looking through, and you can see the cataract there. And this is a sort of a dense cataract where you really can't see anything, and you would be trying to get measurements and it would just be error. So you would use ultrasound to get that. Okay, other things to think about with the anatomy is the retina. The retina is important because that's like the resting place, if you like, of the light coming in. And that's where we take the measurement for the axial length from. So if, for instance, like this case, we have got a retina, normally all of it should be nice lines. But here we've got a bump that's been pulled forwards. So instead of the axial length being down here, the axial length is actually up here. And that will mean that you'll measure a shorter axial length than you would otherwise. And it will mean that the patient's vision won't be so good after surgery. This is the vitreous, these little wings, they look like bat wings. And normally what will happen is these will snip off just naturally, and then all of this area, the macula, will fall down and the patient's vision will return to normal. Okay, sometimes so it doesn't and it tears, and that's when you develop a macular hole. Okay, so certain pathologies need OCTs really, or photographs or ultrasounds. It depends what information your doctor wants. But these would be the patients that have got something going wrong at the macula, which is going to affect their vision, okay? And the doctor wants to know, well, does that need seeing before I do the cataract, or do I wait to do the cataract and do the surgery afterwards, okay? So, I won't ask you any questions, but if you do have any questions at this time, please can you email me, emma@clinicaltrainingsolutions.co.uk. Okay, so cataract. As we said, it's an opacification of the lens, and the classification can take into account how the cataract was formed. So was it by age? Was it trauma? So that person with the dart in the eye, that would definitely have caused a lot of trauma, and that would have caused a cataract. Drug induced. So by this, I mean certain sort of steroids and that, which are going to induce a cataract. And also diabetes, that's also causes cataracts as well. Then you get babies who get born with it, and so you have little 6-month-old babies having surgery. Okay. You can also think about it in terms of the position. So we've thought about it in terms of the classification, and now you can think, okay, well, the cataract is in the middle, therefore it's a nuclear cataract, or it's subcapsular, so it's at the back of the bag, if you like, at the back of the bag that holds the lens. Okay, so there's lots of different ways you can categorize by how dense the cataract is. And what I suggest you do is work with your doctors and ask them how they classify. So when you're going into theatre, you will ask the doctor, can you just tell me what stage of cataract that is? And then you can get an idea of what it is. So how we see. When we talk about emmetropia, this means that we have perfect vision, and light entering the eye is bent to come to a focus on the retina. Okay, so here is our normal eye, and here is the light, and that will focus straight onto the retina, okay, because the length of eye is exactly in the right place. Now, in myopia, the eye is too strong, and this is also known as short sight, and it means that light entering the eye is focused short of the retina, okay? So if you look at it, here, you will see that the light comes in, and because the light is bent too much or the eye is too strong, you get it coming in front of the retina, okay? So this is why it's called short-sighted. They often have long eyes, just to confuse you. And then in this case, if we give them a minus lens, what will happen is some of the power will be taken away, and then the focus is nice and clearly on the retina. Okay, so minus glasses are myopes. That's how I remember it. And short-sighted patients are myopes as well. And then hyperopes. So hyperopes, this is where the eye is not strong enough. So the light is going to focus behind the retina, and we need to give them a stronger lens. Okay, so normally this looks like an eye here where the focusing is going to be behind. And so to correct them, we give them a plus lens, and then this will mean it will give them extra power, and then they will focus onto the retina. So that's going to look like these big, thick lenses. Okay, so here, the other one is astigmatism, and this is where the eye is focused in two different directions. Okay, it basically means that the lens is two different powers, 90 degrees apart. Okay. And if you hold one of these cylinders up to a straight line, what you'll find is that as you move it, the line up here won't move, but the line inside the eye will move. Okay, so that means that there is a stronger power in one direction to the other. Okay. And then summary. So this is really just something funny that somebody put on LinkedIn for me. Basically, if somebody is emetropic, a male is emetropic and he's going for a pee, then his pee will go straight into the bowl. Okay. A hypermetrope, the pee stream isn't strong enough, so it actually flies over the back of the toilet, whereas the myope, his pee stream is too strong so that it doesn't even reach the eye. And then astigmatism, it just goes all over the place. So I thought that that would be something funny so that you could share with your colleagues. Okay, and then the last type of eye is the presbyopic eye. So this is where the patient, they've maybe coped all through their life without glasses, but now the mechanism, the lens and the muscles are starting to get a bit tired and they're finding that they can't see to read. So they need to put on a plus lens so that they see to read. And this prescription is really designed for about a third of a meter. So here, if I looked around, I would see everything a bit blurry, but in this sort of idea, third of a meter, then I can see everything nice and clearly with these lenses. Okay, and this is the average dimensions. So here, I won't go through them too much because you've got them on your handout. So what I want you really to do is to be able to start looking axial length, K reading. Okay, just start with those two. And then as you get better, start looking at anterior chamber depth. Okay, and you want to have a look at your patients and see how many patients are normal, how many in the normal range, or how many are kind of spot on the average figure. Okay, and it will just help you get to learn those numbers. Okay, and then the other sheet is things like IOP, lens thickness, retinal thickness, anterior chamber angle. So these aren't as important when you start doing biometry, but once you are doing biometry and you're getting good at it, then these measurements are quite useful as well. So all the average measurements, that's really homework for you to go. And if you have questions about them, then please come back. That's fine. Spectacle prescriptions, I'm sure you see them all the time. This is a prescription, it's an American prescription, and I know that because it says Massachusetts up here, and I also know it because down here it says plus 0.50. In the UK, we say that this has to have a 0 in front of it so that we know that the left eye is plus a half. Otherwise, we might think it's plus 5, and that would be a big mistake. Okay, so our most of the things would be to 3 decimal places with a minus or a plus up front. Okay, here again, minus 0.25. This again could be minus 25. Unlikely, but it could be. So you want to just check that. It's all in the British Standards, which if you look on the British Standards website, they'll have things like their spectacle prescriptions will be on there. Okay, so this is what a basic prescription looks like. And then we have this thing on here called the ad. Now, normally we work with a distance prescription. If the doctor asks for a prescription, they want the distance prescription. Okay, they're not really interested in the reading prescription because when the lens is taken out, so has the eye's ability to read gone. Okay, so prescriptions for your biometry patients are normally based on the distance prescription. Okay, but just say you were interested, what did this ad mean? What the ad means is that we add +2 onto the distance spherical, the distance sphere, sorry. And so here, if we add +2 onto plus 0.5, we would end up with an add of plus 2.5. The reading prescription, the cylinder would stay the same. So the reading glasses would be plus 2.5 minus 1 axis 80. But for convenience, most people will just put it as the distance prescription add plus whatever. Okay. And the spherical equivalent, the reason I mention this is, if you do visual fields, you'll be used to this because you have to work out the spherical equivalent to put a trial lens in front of the patient. But also sometimes trying to look at data and work out, is that good outcome or bad outcome, is very difficult when you're looking at spheres and cils and axes. So one of the quick ways is to create the spherical equivalent, which will let you compare lots of different eyes with each other. And you see it used in studies and things like that. Okay. So also we do the same thing in K readings. Sometimes a doctor will ask for a K mean, and you think, what is that? And it's just the K1 added to the K2 divided by 2. Okay, but we will do that later. So we're going to look at the spherical equivalent, and the formula for that is the spherical equivalent is equal to the sphere plus half of the cil. Okay, so it just gives you an average taking into account the sphere and the cil. Okay, so here for the left eye, if we add the sphere and then we add half of the cil would be minus 0.5 and the sphere is plus 0.5. So you add those two together and that says the spherical equivalent is 0. You can ignore the axis, okay? So that's fine when you're dealing with small prescriptions and when you're dealing with data, a large data set. But sometimes, maybe that's your only patient and you wouldn't consider leaving them with a cylinder of a diopter very good, okay? So spherical equivalent can be used to sort of hide what's going on with the prescription. So always look at the range. So if your range goes from of results goes from plus 0.25 to minus 5, that isn't going to be a very good set of data. And look at the numbers that are in each data set. And then types of chart. So this is the Snellen chart. I'm sure you're all familiar with this. The top letter is the distance that we've tested at. So maybe that's 6, maybe that's 4 meters. And then the bottom letter is the line that the patient can see. Okay, so for here, if they see down here and see 6, 6, that means at 6 meters, they can see the letter. They should see it 6 meters. Okay. At 636, which is up here, that means that at 6 meters, they need the 36 meter letter, which is going to be much bigger to be seen. Okay, and then you can also add pluses and minuses to say, whether the patient was doing a little bit better or a little bit worse, okay? But generally in ophthalmology now we've moved over to logmar tests, and that's because they will give us a score. So it was developed for a diabetic study quite a while ago, and then one of the big pharmacy companies that was doing Lucentis, Novartis, they came up with using this chart in their studies. So then a lot of the hospitals that were involved in the studies were using these charts, and now everyone's seen the benefit of them, and certainly with retinal patients, injections, all of those things, this chart will give you a score for each line. Okay, so there's 5 letters on each line is worth 0.1 and each letter is worth 0.02. Okay, so the logmar is going to give you the best line read minus, and then you do 0.02 times the last letters. So the last letters on the last incomplete line. Okay. So if you look at the chart, the idea is because you've got all of the letters on here, 5 letters on each line, you will be able to give the patient a score, and then you will see, if they've got good vision, or more importantly, you can compare them visit to visit, or you could compare their vision before surgery with after surgery. So logmar charts are very, very useful for doing that. Okay, and this is the near vision chart, which we don't really need to get involved with too much, but because we know that we're going to remove that lens, and that's going to mean that the lens that's going in is going to correct the patient. But sometimes it's good to look at these charts and see which notation that you're using. So this is a number 1 all the way through. Okay, it's not just the size of the letter, it's also to do with the presentation of how close the different letters are to each other. So all of these things can affect, and obviously how many coffee cup stains they have on them. So most of the ones I've seen recently have just had coffee cup stains on, which defeat the object of using this pristine white test. Okay, and then this is just something about words that you might know or you might not know. So if you have any words throughout the course that you're unsure of, then we can start to populate this list. Okay, so please send me messages if you want any help, and if you can think of any words that you don't know, we can look them up for you. But today we've looked at the anatomy, so this will give you a good introduction to the cataract, vision, this is important, and average measurements. So when we start next time, we're going to be looking at biometry, and we're going to be looking at doing measurements, and we're going to be talking about different eyes and giving them different names. So hopefully that will, when we start doing that next week, this will help you. Okay, and we looked at spherical equivalent and the test charts. So thank you very much. I hope that you have enjoyed this. Send me your questions, and I will see you for the next module, which will be biometry.